Yeah, I think right now when we look at risk stratification, we're largely doing so to identify patients who we could consider a curative approach with allogeneic stem cell transplant. And really we're identifying those patients we consider to be high risk. Historically, we used clinical factors for that because that's what we had. We looked at white blood cell count, hemoglobin, constitutional symptoms, age, circulating blast. Increasingly, we've started to incorporate more genetic factors, and I think these updated prognostic models, which are much more confusing, but you know what, the disease is confusing, so the prognostic models should be confusing as well, but they often have these online tools that we can use, these risk calculators that make it easy and more reasonable to use these in practice, and those start to incorporate high-risk mutations in U2AF1, SRSF2, ASXL1, among others, high-risk cytogenetic features, in addition to some of these clinical factors that we know still have value, right? But maybe some of that value is linked to some of these mutations. Now, do they cover every mutation that's bad? No, I think there's other mutations that are out there that really play a role, and certainly those could be added into future scoring systems, which will make them all the more confusing. But what we need to realize is the addition of these other mutations, the patient sitting in front of us, their clinical factors, all of this can help to identify this patient. I think going forward, you could talk about stratifying patients by additional mutations, but you can also look at the relative allele fractions of those mutations. That's not included. Maybe having a dominant clone that has both an ASXL1 and an SRSF2 mutation is different than having a very minor, low-level clone that has those mutations. I think that's very difficult to look at because where do you draw the line? You're making artificial cut points to do those studies, but I think that's sort of the gestalt that we get when we look at these patients is all that stuff matters, but how to actually put that into a model may not be there. So I think our understanding is getting more three-dimensional of the disease, and unfortunately, we have not factored in the impact that treatment has on all these factors, right? These are largely treatment agnostic prognostic scoring models, just looking at the patient, ignoring the fact that we may come up with therapies that could modify the underlying disease. And so I think that'll be important too, is really understanding, risks for patients who are actively being treated, right? There's a new model called the RR6 model that's looking at predictors for survival in patients that have been treated with ruxolitinib. And I think that'll be important to look at as we identify patients who may benefit from combination therapy, change in therapy, new clinical trials, and these are all going to be very important to keep an eye on.